Today, I have an incredible interview for you. I interviewed Dr. Amy Killen. And if you're not familiar with her work, Dr. Killen is one of the few hormone experts that I feel like I learn from every time I hear her talk. She is a big advocate for using the term hormone optimization therapy rather than hormone replacement therapy because of the differences in the way that she sees hormones, how they interact with her patients, and how she's using them. What she's doing is relatively unique through the lens of optimization, health span, lifespan. She talks a lot in her work around longevity, and we get into that in this podcast today. But her work is very much focused on women's health, women's hormone optimization. We're going to talk about that today, as well as a little bit of men's optimization, testosterone. We also get into really the strategies and even the tactics around how to prescribe and how to, as a consumer, receive estrogen, progesterone, testosterone, thyroid. The way that she's doing this clinically, she really opens the door for us to see on the inside what she's thinking and what she's doing in her clinical practices. So, super exciting interview. If you want to step outside of the traditional hormone replacement therapy guideline driven conversation, then this one's for you. Welcome back to the Health 3.0 podcast, brought to you by LifeMD. I'm your host, Dr. Doug Lucas, orthopedic surgeon, head of longevity medicine at LifeMD. Each episode, I sit down with the innovators, disruptors, and clinicians redefining what's possible in modern medicine and what that means for your health. Let's get started. All right, Dr. Amy Killen, thank you so much for joining me on the Health 3.0 podcast. I'm super glad to have you here.
Thank you. I'm excited to talk to you. I think we have a lot in common.
Oh, I know we have a lot in common. It's just the beauty of social media. And we, just so everybody else knows, we've met briefly one time, but there are so many things that we could talk about. I'm just going to lay out a couple of things that I know we have to get to, and then we'll see where else this goes. I definitely want to talk about hormone optimization. I heard you once use the term hot, and I want to use the term hot moving forward. In fact, it's all I say right now. So we got to talk about that. I definitely want to talk about kind of the menopause movement, what's happening with care and treatment and how things are moving in the right direction, but maybe in ways that we could move in different directions. And then I also want to talk about this concept of longevity because it's a relatively vague word. And I know you have some strong feelings. So I want to get into all of those things. Before we do that, tell us why we should listen to you on these topics in particular.
Oh, a hard question first. So I am a former ER doctor. I'm board certified in emergency medicine. I did emergency medicine for 10 years, but ever since 2013, so the last 13 years, I've actually been out in this world doing a lot of hormone optimization. I do integrative medicine. Now we kind of call it longevity medicine, but I've been in this proactive preventative medicine space for a long time, but also I'm still grounded in allopathic medicine. I still believe in medicine, but I also believe in, integrative therapies. And I teach courses. I have my own hormone course. If you're a medical provider, by the way, I luckily have been able to speak on stages all over the world about these topics. So I don't know if you should listen to me more than somebody else, but I do have a lot to say about these things.
Yeah, well, I appreciate that. It is, this is an interesting position to be speaking as emergency trained physician traditionally, and I'm an orthopedic surgeon by training, and yet we've both found very unique pathways to get to where we are today.
Yep.
So let's just define the difference between hormone optimization therapy as you define it and hormone replacement therapy. I've heard you kind of lay this out, and I've started doing the same thing. But tell me from your perspective, why can't we just use HRT? Like, why do we have to create a whole new thing?
Yeah, it is a little confusing. So HRT, hormone replacement therapy, is kind of the older name that was given to just specifically replacing estrogen and progesterone if needed in women, in midlife women, menopausal women, essentially. And then that kind of changed to menopause hormone therapy being the official name adopted by the powers that be and the places that hold such power. And they said, we should name it what it is. It's menopause hormone therapy. It's just for menopause, et cetera. I, over the last more than 10 years, have always called it hormone optimization therapy, HOT, because I'm not just treating menopause for one thing. I'm treating perimenopause. I'm treating premenopause. I treat men. I'm giving hormones, and I'm not just giving estrogen and progesterone. I'm also giving testosterone and thyroid and other hormones. And also, I think that the idea of optimization is so important. We're not replacing hormones to make them what they were when you were 18. We're not having you cycle. We're not trying to get them to be what they were. We're trying to get those hormones to be what is optimal for yourself, for where you are right now, for symptom prevention and also just I'm sorry, symptoms now and then disease prevention in the future.
Yeah, that's a really succinct way of saying it. That's awesome. So then, the challenge that I have is that when I talk about hormones, I get a lot of pushback because the way that I talk about hormones, the way you talk about hormones, pushes up against the guidelines, what a lot of our listeners, our patients included, are hearing on social media, but also from medical, medical organizations, right? Like American College of Obstetricians and Gynecologists, ACOG, the Menopause Society. The guidelines that are put out and the language that is put out is not necessarily in sync with what we're saying. So I'd love to just spend a little bit of time and not just, pulling them up and walking through them step by step, but in general, as you see it, the guidelines that are out there for, especially let's just talk perimenopause and menopause if we can in general. The guidelines that are out there are, I think, I think they're a little bit vague and I think they're a little bit short sighted. Can you give me your perspective on what's happening with the guidelines and how you treat patients and how those are different?
Yeah, I think that, for instance, the Menopause Society, formerly NAMS, their 2022 guidelines for menopause hormone therapy, as they call it, says essentially we'll give you hormones to treat symptoms that are, not resolved by other things, or if you are really high risk for osteoporosis. Like those are kind of their two reasons that they think that the risks, are the benefits outweigh the risks in those patients. But there are so many other people. First of all, as you well know, almost all women are going to be eventually at risk for osteoporosis, especially thin women, people with family history, et cetera. So the fact that so even just if we just use that guideline, we still can say, well, most women are going to be at risk. So we should think about estrogen. But even beyond that, there's so many other potential benefits, including future reduction of cardiovascular disease and pelvic floor health and things like that. And then of course the symptom piece I think is so important. It's we want to acknowledge that some of these symptoms are debilitating in menopause and then also in perimenopause, and there's not a lot of specific language used around perimenopause, but we have that's a 10-year up to 10-year time period where it's just like, just deal with it. Good luck. We'll treat you when you get to menopause, which is absurd.
Yeah, well, right. Yeah, as I was saying, guidelines around perimenopause, I of course realized that there aren't any.
Yeah, I was just
Um,
thinking, are there any guidelines around
no,
perimenopause?
no, but I mean, you can extrapolate, the recommendations around using hormones into, women that are not quite yet postmenopausal, but it's
Yeah,
difficult because it's a very different clinical scenario, right? And this is where, for me, and how I'm training our providers, same thing. We're talking about optimization because we start looking at this at a much younger age. So we're looking at women in their late 30s and early 40s, and we're asking the question, not how do we replace your hormones, how do I optimize your hormones?
yeah,
And then when you start there and you continue this forward, there really isn't a clear transition point when you go from perimenopause into menopause, right? Like if you're truly supporting hormones that whole time frame, you realize like at some point your patient's going to go through menopause, and depending on how you're doing it, like you might not even actually notice.
yeah.
And that's one of those really that's an interesting point. But then let's go from, okay, the strategy of optimization versus replacement. Let's talk about tactics. So you mentioned estradiol. That's sort of it's the big thing that most providers are thinking. It's what most patients are thinking, honestly, except for maybe right now testosterone because it's really hot. But let's talk about estradiol first. So, from your perspective, when should a woman consider looking for estrogen as a potential therapeutic? What should she be looking for from a symptoms perspective?
So the classic symptoms of low estrogen are things like, vaginal dryness or vaginal atrophy or pain or other kind of pelvic floor, urine problems. Sometimes it's a dry skin, joint pain, kind of achy joints are pretty classic as well. But there's dozens of other symptoms that people don't even think about, like itchy ears and just not feeling like yourself in the morning. Of course, night sweats and hot flashes are very classic, but there's so many things with low estrogen. And we used to think, and we used to say that you don't need estrogen until you are menopausal. Menopause is 12 months after your last period. And so doctors used to say, well, we're not even going to really consider estrogen until you're like fully in menopause, right? That period. Now, I think practice has changed for people who prescribe hormones, and myself included, over the last 5 years or so, and that we start to think about estrogen even in the perimenopausal women if they're either having symptoms or, and this is important, if we're finding lab results or other markers that are showing that their estrogen is declining, then it's causing problems. So we can replace earlier.
Ooh, so you said a kind of a dirty word there. You said lab results. Does that mean
Yes.
that you're actually testing hormones, Dr. Killen? Can you
Yes,
test
I
hormones?
I am testing hormones, and I'm also testing all of some of the other things, I know you are too, the markers of how the hormones are acting in the body. So, it is true that testing hormones is complicated. Like, some of the rationale by people who don't want to test hormones is it's too complicated. Like, we have to look at when you took the hormones, we have to look at what type you took, we have to know about your metabolism, we have to, like, it's complex. We have to look at the lab assay. All of that is true. And certainly when you're in perimenopause, it's even more complicated because you've got crazy, the cycles are not even normal. And so I would say, yes, that's true, but we can still get a lot of information from those hormone tests. And we should also be looking at other markers of how the hormones are acting. Like, we should be looking at your inflammatory markers because we know inflammation goes up when estrogen goes down. Your lipids, same thing. Your visceral fat, your bone markers, because all of these things are affected by estrogen. So if we're not checking labs regularly and strategically, we are missing all of these markers of aging that are going to eventually harm you.
Yeah, I guess that's such a great way of saying it. There are days when I wish I didn't check labs. Do you ever
Yes.
have those days?
Yes. It'd be so much easier not to check
Oh,
labs.
God, it would be so much easier. But I, especially in the space that I will get to your, like what you're doing clinically in a little bit. But for me, I mean, from bone health perspective, you mentioned it, right? If we're looking at hormone levels and bone turnover markers, we can draw such great conclusions from putting this big picture together that can really help women to understand if what they're doing is doing them any good.
Yeah,
And that's the question we get so often is, do I need to go up in my dose of whatever I'm on? Um, is this actually preventing bone loss? Like, I mean, this is the world I live in every day. Am I
right,
actually protecting my bones? And if I'm not checking labs, I can't say, and I don't want to wait 2 years to get another DEXA.
right.
Right? Like, it's way too long. So yeah,
Yeah.
so let's dig into testing a little bit because the questions I get generally are just that, like what estradiol level should I be aiming for? I mean, you kind of just said it. It's a lot of things altogether, but do you have some benchmarks that you're aiming for different outcomes?
I in general, I like estradiol in serum to be between this is in menopausal women who are on therapy, to be between minimum of 65 and then up to usually 150 or so. Some people need more. I think it, and I know that some women need more than that, but a lot of in that kind of sweet spot is good for a lot of women. And then also taking into consideration, obviously, your symptoms, how you're feeling. Are you having, too much estrogen? You have breast soreness, and are you crying in movies? Like, maybe that's too much. So I think it is an art as much as anything. But
Totally.
when you do it for a long time, you do start to see patterns that you can recognize, and you can say, you know what? Like, recently, you'll appreciate this. I had a patient who was in her early 50s. She'd been on hormones for a number of years, and she came in for feeling fine. But when we did a DEXA scan on her, she was fully osteoporotic all the way down. And I checked her estradiol level in her serum, it was 20, which is essentially the level you'd have if you weren't taking hormones.
Right.
She thought she was doing such a good job. She's taking hormones, she's paying out of pocket, she's seeing a doctor, but nobody was checking her levels. And so no one knew that she was actually becoming more osteoporotic.
Do you remember off the top of your head what she was on?
Yeah, she was on Biased, and she was on a teeny tiny dose. So, Biased is a combination of estriol, which is a very weak estrogen, and then estradiol, which is a good strong estrogen. And, I'm not really a fan of Biased. I don't think it has really a lot of purpose. But if you're going to use it, at least make sure that you're getting enough estradiol, which is the main kind of needle driver. And she was not. She was just getting a teeny tiny, what I call fairy dusting dose of estradiol.
Yeah, it's like the placebo dose, right?
Yeah.
Um, Unfortunately, the placebo dose doesn't work for your bones. You can't fool them into making more bone.
Yeah, they're smart.
Yeah, there's a study I point out in a lot of the talks that I do. There's an interesting study from the early 2000s that was really it was an estradiol dosing study for bone density, and it showed what you would expect it to show, which is more estradiol, better bone protection. But what they did, which was really interesting, is they used estriol as the placebo arm.
Oh, So funny. That's
right? And
awesome. Yeah.
and the authors even said, they said, "We used estriol because we knew that it wouldn't protect bone."
I did not
And
I knew that estriol did not protect bone. I did not know about that study because
yeah,
bones, as you know, are very sensitive to estrogen. Like,
yeah,
estradiol, even at a low dose, does help bone. And I think that's one thing, women are told, "This is gonna help your bones no matter what dose we give you." And that's true. I think that's probably
it's true.
true. It will
Yeah,
help, but it's like, well, how much help do you want? Like, if you just want it to help kind of slow down your bone loss, then a very small dose may do that. But
we'll
if
do
you're
that.
actually wanting to prevent bone loss or even, heaven forbid, build bone, then you have to have enough of that estrogen.
Whoa.
I feel strongly about dosing because it's one of the things that is still I still that all the organizations, they just talk about dosing to treat symptoms, and I think that is such I think that logic, yes, we want to make you feel better. Yes, we listen to symptoms, but there are very few other medications that we give for prevention where we just say, "Well, just see how you feel and let me know, and we'll adjust the dose based on that." Like, we just don't really do that in medicine because we like objective data and we know that's what actually counts, and yet we don't apply that to women's hormones.
Well, and I think, I mean, to be fair, because I'd love to sit on both sides of this fence and say, okay, well, from a cardiovascular disease perspective, like we don't have good biomarkers to know how much is enough, unless you do, and I'd love to hear it. But same thing with dementia prevention, cognitive function. I mean, something we do need to ask questions, and this is where I also like I sort of look at some of the protocols for these telehealth companies because I help build one, where they're not even asking symptoms, right? They're just like estradiol patch, like this is all you need. Um, and so I do think we need to ask questions, but where we can get biomarkers that matter, it's so important. And not to keep coming back to bone, but bone is literally telling you, right? The
Yes.
CTX biomarker is telling you what's happening in the cells. It is so valuable. And yet the vast majority of doctors are either telling me that I shouldn't be using it or they just refuse to use it.
Yeah.
So we hope to change that. Now you mentioned like dosing is important, but I would love to know how you like to actually give it. So what forms do you like? Because if we're just talking about commercially available, we start to get a little limited. How do you approach that?
So I'm a fan of both commercially available forms as well as compounded forms. I think it's important that doctors know how to use both because I think they're both, there's places for both. I like both transdermal estradiol and I actually also like oral estradiol still. I think that when it comes to, for instance, the cardiovascular data, we have randomized controlled trials that show that oral estradiol prevents cardiovascular disease in 3 studies. We don't have any studies yet on transdermal estradiol and
Yeah.
cardiovascular disease. And so it doesn't mean it doesn't, it certainly still may work. But when you ask about, like, well, what do we know? We know that 1 to 2 milligrams of oral estradiol reduces plaque thickness in your arteries in your neck and reduces cardiovascular disease and outcomes. We don't know as much from that standpoint about transdermal. We do have some good observational data. But the point being, I like oral, I like transdermal. I don't use pellets for estrogen. I do sometimes for testosterone, but not estrogen.
Yeah.
And I'll use patches. But I also use like compounded versions of estrogen. I like to use different bases and things like that, and experiment a little bit. So it's a fun world to be able to pull from all of these.
So lots of different things. Okay,
Yeah.
so this will be fun. So I currently do not support in my clinical practice using oral estrogen. And the reason why is because there is according to my interpretation of literature, a very, very small
Right.
increased risk of blood clot.
Yes.
So walk me through because you clearly know the data very well. So walk me through how you get around that yourself.
Well, first of all, I don't give oral estrogen to anyone who has a significantly increased risk of blood clots. So if you are a smoker, if you're obese, if you have had a history of blood clots or family history, then that's off the table. If you've been more than 10 years without hormones, like if you're 65 and going to start hormones, I always just use transdermal. But in someone who's low risk, the risk is actually very, very slow, very, very low. In the Women's Health Initiative, they use synthetic estrogen, which is, the conjugated equine estrogen, Premarin, which, is actually is more likely to cause clots than estradiol. And in that study, they saw twice as many blood clots in the Premarin group. However, the actual numbers are very small. It's, placebo was 14 blood clots out of 10,000 person years, and Premarin was 34 blood clots out of 10,000 person years. And then we have the data that we have on estradiol is that it actually causes clots less than Premarin. So it's probably on the order of maybe 1.5 times risk. So it's still there. It's not negligible, but when you think that birth control pills increase blood clotting by 4 to 8 times, and we're talking about maybe 1.5 times for estradiol, you just got to kind of put it in perspective.
Right. Yeah, and that's, when my provider is asking me about that, and this is I can walk myself into using it. I think the biggest thing that we're missing out on with our protocols right now is that because we don't have an oral estrogen as an option, is women who don't do well with topicals, right? If you don't do well with a compounded or a transdermal patch or a gel, I don't really have a good solution for you. And
Yeah.
that's where oral could be very valuable.
Yeah, or like my mom who is in her 70s still, and she's been on oral estradiol forever, and I realize that she's probably, she's older, she's had a higher risk, but she was recently changed to a patch, and the patch is like 100 something dollars a month, plus there's a patch shortage, versus oral estradiol was like $15 a month. Like, there are some cost differences to think about, I think, with these different forms. Obviously, it depends a lot on what your insurance pays for and where you get them, but, there's a lot of options, I think, is the main thing that women should understand. There are very, very safe options. There are probably pretty safe options, lower cost, higher cost. We can do a lot with these hormones.
Yeah, that's some of the challenges too of actually running a clinical practice is there are a lot of options.
Yeah, yeah. I'm the chief medical officer for Humanot Health, and we have clinics in Texas and Florida right now, and working on our next one. And just trying to put down, I have this enormous spreadsheet of kind of like the options. And what I realized is that there's too many options. Like, the medical providers are like overwhelmed by these too many options. So I need to like condense them down. But it's tricky because we want to give people options, but we also don't want to overwhelm.
Yeah, well, I'll take it a step further. So one of the initiatives at LifeMD is to be able to provide inexpensive medications for either, right now for cash pay, but and eventually an insurance, because we are so big that we have the ability to leverage that. But then we have to actually have inventory, and so
Yeah.
having inventory on all these products that's a huge
Yeah.
challenge.
It's a big
Yeah,
lift.
yeah. It's fun though. I mean, I love being able to bring that price down because, like you said, badges are expensive, and if you can't get them, that's a problem.
Yeah. That's
Do
true.
you think that's because of the change to the black box warning? Did that just blow up the market?
I don't know. I think that's probably part of it for sure. I think there were a lot of doctors out there who were kind of on the fence, like didn't know for sure if they should, like maybe they were prescribing some hormones, but not a lot,
Yeah,
because they were still kind of scared. And I think that with the black box warning coming off, those doctors are now like, okay, I realize that this is really safe. You need it. Let's go. So I think that's good. I'm happy that that's happening.
right, yeah. Maybe there should be some coordination between the FDA and the, pharmaceutical industry next time.
I feel like there's a lot of coordination already.
Not the right kind.
Yeah.
Not the right kind. Okay, well, then let's shift to progesterone. I look at progesterone as sort of like the forgotten hormone. And
Yes.
of course, the recommendations, the guidelines are to only use progesterone in conjunction with estradiol therapy to protect the endometrium, the lining of the uterus, from hyperplasia, growing, potentially endometrial cancer. What are your thoughts on progesterone? Why do we use it?
Yeah, I'm a big fan of progesterone, and I tend to recommend progesterone with estrogen in most women as long as they can handle it. And there's some people who really can't, but I do think that I feel like progesterone is kind of the yin to the yang with estrogen. It's going to it's going to kind of do the opposite of what estrogen does, or sometimes just kind of helps estrogen be a little more organized in the way it works. And so I like it a lot. I think it's great for sleep. It's great for mood. It's great for kind of reducing anxiety if you take it at night. And I do give progesterone even if people don't have a uterus most of the time.
Same. You mentioned, tissues across the body. I'm mostly interested. Well, I talk a lot about bone health, and there are no studies looking at progesterone alone in bone health. So I can't say how good is it. I don't know.
Yeah.
But I'm more interested from a safety perspective in what it does in the breast with the breast tissue. So what are your thoughts on how it would balance? What's the yin to the yang when it comes to breast tissue and estradiol?
So it's really interesting because we have a lot of mechanistic data, animal data that progesterone is anti-proliferative in the breast. It's kind of estrogen, of course, is going to build the tissue up, and progesterone kind of helps keep that from happening, right? So we have that, and we have a lot of data on that. But then there's also some intriguing, I think we understand why, but there was the group that took the progestins, the synthetic progestins, not progesterone, but the progestins in, the Women's Health Initiative and other studies, including studies on BRCA gene carriers, where those people actually have increased breast cancer risk, or at least not increase. Maybe it's not, it's essentially if you give estrogen alone, you're decreasing risk, but if you give it with a progestin, maybe it's a neutral risk. So some doctors argue, if we know estrogen alone, at least certain types, can decrease breast cancer risk, then why would we give progesterone to those people? But I think that there's so much nuance here. We're talking about synthetic hormones for both of these, from in most studies, synthetic estrogen, synthetic progestins. We're not talking about bioidentical hormones. So we need to learn more, but I still think that progesterone is breast protective more than it is problematic.
Agreed. I also find too, like I have very few patients who are not on progesterone, but I do find for the very few that they are more likely to be sensitive, like especially breast tenderness,
Yeah.
with higher doses of estradiol. So it just seems clinically, it seems to balance that out.
Yeah, absolutely. I mean, unfortunately, there are, 20% or so of women have some issues with progesterone. Like it either makes them too drowsy, too sleepy, or it can make them anxious and irritable and they can't sleep. And so we had to kind of experiment with forms of progesterone.
Hmm.
Instead of just giving pills, we have to do other ways. But it's a task that is not, we can do it, and usually it works for most women. We can still give it to them.
Yeah. Can we talk about the options? Because I think a lot of women, 20% sounds right to me. And we have a strategy for that. But I think a lot of women, this is one of those conversations we hear where they say, I tried hormones, it didn't work for me, so I stopped.
Right.
And I think it's so unfortunate because there are alternatives. So let's say, a woman starts, let's just call it simple, some kind of transdermal therapy for estradiol, and she's using oral micronized progesterone. She doesn't tolerate it. So tell us first, what does that feel like? Like, what does intolerance feel like? And then what do you do about it?
So there are actually 3 different types of intolerance to progesterone. One of them is just that you're more sensitive to it. So most women, when you take progesterone at night as a pill, it makes you a little more calm, a little less anxious, a little bit more likely to sleep, and that's great, and we love it. Some women are just more sensitive to it so that when they go to sleep, they don't wake up as easily in the morning. They're kind of too drowsy the next day. Maybe their mood is kind of flat. And so that's one form. There's also a form that's called paradoxical progesterone response, where essentially what's happening is their brain is reacting to progesterone like in the opposite way. Instead of binding to GABA, and GABA like relaxes you, it binds to GABA, and then the GABA is excitatory. So it makes these people feel really anxious, and they feel stressed out, and they can't sleep. And it feels pretty bad. And so that is paradoxical. And then the last one, which is very rare but still out there, is an actual allergy to progesterone, where you get like hives and flushing and swollen face and potentially severe reactions. But usually, with the first two at least, if we change for to a non-oral form, so not a pill, we can reduce those symptoms, because a lot of the symptoms are due to a metabolite of progesterone that we can reduce if we give it like vaginally, rectally, sublingually, or even as a cream if you're watching the uterus.
Yeah, I'm glad you mentioned that last one. I was going to ask you. So, because there are a lot of women who are using creams, and either they're finding them on their own, or they're working with some kind of a natural-ish functional provider who uses a cream. And the thing that they are often told by their maybe more traditional provider is that that doesn't protect your uterus. So we also have a cream option, and we do use it for some patients, but same thing, we monitor the uterus. So what does that mean to you? How are you actually helping them to protect their uterus, assuming they have one?
Yeah, I mean, I don't give a lot of creams, but I also do recognize that there are very good, smart doctors who do and are not, they're watching closely, and you're not seeing endometrial cancer in those patients. So the reason that they're not given is because the studies that have been done with creams, they don't reliably protect the uterus in women who are taking estrogen. So if you're on estrogen, you're supposed to kind of pair it with the progesterone to protect from cancer developing in the uterus. And creams sometimes protect, but they don't reliably protect. That's the kind of word on the street. But a lot of doctors are giving creams in pretty high doses of progesterone, and then they're just watching they're doing an ultrasound once a year, or something like that, where they're watching the endometrium to make sure it's not getting thick. And if it's not getting thick, then that's good.
Yeah, agreed. And that's what I mean by watching too. You have to look at it,
Yeah.
with an ultrasound.
Yeah, exactly.
Um, and that's the thing is I hear some doctors say never, never use creams, but it's like, no, you don't, you just have to be smart about it, and you have to follow those patients and make sure that they are being monitored.
Yeah.
The challenge I think with most creams is they're just not strong enough,
Yeah.
right? Or they're not made well. And if you use an appropriate strength cream, then it is not an issue, which actually brings me to the next topic I wanted to talk about, which is because we're starting. I think just like you are, we're starting the conversation around hormone optimization in perimenopause. So we're supporting a cycle rather than replacing hormones just to either, squash it or whatever
Yeah.
you're trying to do to the cycle. So we're supporting the cycle. We want the cycle to continue really for as long as possible. So that means that we're cycling progesterone typically. So when does that end for you?
I think you and I have different, perspectives on this, but
Yeah.
I don't think that we know for sure the best way to do it, but I will say the way that I tend to do it is if she's cycling, then I cycle progesterone. If she's cycling regularly, we'll cycle it, we'll cycle it in some way, giving her either only in the luteal phase or at least more in the luteal phase of progesterone. If she's either not cycling regularly, like she's got PCOS or some kind of other thing where she's got erratic cycles, or she is not cycling at all, I tend to just do it every day. And I believe that you have talked in the past about that you still think maybe cycling has some benefits, which I'd love to hear about if that's true.
Yeah, I will say here the research is not as robust as I'd love for it to be. I think in general, just from like a big picture perspective, whenever we can support the body to do what it would do naturally, I think we should do that. Right. And so I think there's a lot of power in having normal cycles for women. So if we can support that, I would rather support that. That said, the question is then when do you like how far do you go? Because I do have a number of colleagues that will push as far as like, artificially creating a cycle, right? So you're actually cycling estrogen, progesterone, you're creating a menstrual cycle, and when you push that far, then you really have to ask yourself, like, when do you stop? Because this is what I was saying. If you support perimenopause to that extent, you don't know when a woman goes through menopause. So then when do you actually switch to static therapy? And that's a big fat unknown. Um, I look at this mostly from the bone perspective, which is every cyclic study that I've ever seen, if they had a cyclic versus a static arm, cyclic was performed better, but they're all small studies. And so, take it for what it is. I love to pick brains of providers who are treating perimenopause because it always comes up like when do you switch? And so then for you, you would know when your patients are going through menopause. You know when they stop cycling.
Yeah, I know that because I'm not giving them, crazy high doses. I'm not there was like a old Wiley protocol where they used to do that, I had patients who would come in on that sometimes when I first started hormones, and I was like,
Yeah.
"What is this?" I had to learn about it. But yeah, I think that I do know when they're I mean, I don't know always where they are in perimenopause because
Yeah.
that's a tricky time, like, it's a lot there's a lot going on there. But certainly when their cycles stop, I know. And I understand completely. I think that I could see the rationale for doing cycled progesterone, and I'm not opposed to it. We know that it's still protective as long as you give it for 12, consecutive days at the right
12
dose.
days. Yep.
But from me, and I guess the main issue is a lot of patients love progesterone, so they don't want to be without it for 2 weeks. Like they don't want to.
Right.
All of the sleep is not as good. They're more anxious, whatever. And then also some of those women who are taking it, cycled will have a withdrawal bleed, and sometimes women are in their 50s or 60s are like, you know what? I'm done with bleeding. I don't actually need to bleed anymore. So it's more of a convenience, but I would love to see more data. I think we definitely need more of that.
Yeah, I would love that. And I think it is interesting when I hear somebody say like, "Oh, yeah," a woman says, "I'm cycling, I'm postmenopausal and I'm cycling, but I don't bleed." And I asked them like, "Well, do you have a uterus?" And if you do and you're cycling and you're not bleeding, that means you actually probably don't you're not optimized. That means you don't actually have enough estradiol because you should be building up your endometrium
Yeah, that's
from
true. You're
that
probably
perspective.
taking baby doses and not getting enough.
Right. So then next then we have to reevaluate all of this anyway. But yeah, I'm not here to tell any postmenopausal woman she needs to bleed on a regular basis. There's zero evidence to support that there's a big enough benefit to offset that inconvenience.
Yeah.
So I'm not here to say that. Um, I do think the research I would love to see it. And I've heard that there are some studies going on out there, but I've not seen them or any
I feel
data
like it
from them.
wouldn't be that hard to do. I mean, it would require someone to follow some things, but I don't think it would be that hard to do. Like, but who knows? It's apparently difficult to do research on women in general.
Apparently. Apparently. So we should just do it all on men.
That's right.
Let's go back 50 years. So, okay. Can we move to testosterone?
Yeah, we can.
Should we talk about sexual health first, just like in general?
We can definitely do that.
And then either way into testosterone. And the reason why I would say let's talk about sexual health now is because there are a lot of women who don't have access to testosterone, or they're afraid of it, their providers are afraid of it, or whatever. I have found that if we optimize rather than just replace, if we optimize estradiol and progesterone, a lot of times the sexual side effects, because we use the menopause rating scale, so we see and we ask, we talk about these things, the sexual difficulties a lot of times will get better
Yeah.
with simply estrogen and progesterone when they're optimized. What are your thoughts on that?
I think that's true. What's interesting, as you know, with when women go through menopause, estrogen progesterone production by their ovaries falls off a cliff. Like you go from making a lot to making very, very little to none, right? And so that's a big drop. What doesn't happen is you don't stop making testosterone. That was a double negative there together, but you
I got
don't
you.
stop making testosterone. Your ovaries still make testosterone and your adrenal glands still make testosterone. So even though testosterone has been slowly going down starting at about age 25, so it is coming down just like with men. You don't have that fall off the cliff like you do with the other two hormones. So what
Right.
can actually happen sometimes, and I think it's not talked about enough, is you lose estrogen and progesterone, you still got some testosterone, but the ratio has changed. That estrogen to testosterone ratio has changed. You used to have, about twice as much testosterone as estrogen. And now you've got like 4 or 6 or 8 or whatever times more testosterone than estrogen. And so sometimes women will have like these sort of androgenic symptoms. You start to notice some chin hair that's like dark, or you start to have, like some things like that. You're like, what is going on? Without taking testosterone therapy, because estrogen has come down relative to testosterone. So I think that testosterone is a great tool as a therapy for the people who need it. I think it's an as needed hormone. I don't think it's an everyone needs it hormone.
Yeah, I have this theory, and I'd love to know your thoughts on it. When we look at testosterone levels in men and in women over the last couple of decades, it seems like the levels have been declining for both, really. Regardless of age, the levels are coming down. I think that likely if we went back, let's say 50 years, and we were to do the same, let's use like the menopause rating scale. You do the same instrument for women going through menopause 50 years ago versus going through menopause now. I think that women are having a harder time now because of lower testosterone. Does that make
Mm.
sense?
Yeah, that could be. I mean, we do know, like, if for women who can't take estrogen, of course, Rebecca Glazer has done a lot of research on this. Like, she's a big fan of testosterone pellets in high doses, and she treats her patients with testosterone, the ones who can't take estrogen. So she just gives testosterone and progesterone, and she does see decrease menopause symptoms, decrease hot flashes, night sweats, body aches, all that stuff from testosterone, and not because it's being aromatized into estrogen, but just the testosterone itself. So it's your theory is possible.
Yeah, it's interesting. And is she using any kind of like an AI to prevent that aromatization?
So in her, she's published a number of studies over the years, but yeah, she'll use an aromatase inhibitor in some patients, like
Mm,
patients who are breast cancer survivors
yeah.
and are not supposed to have estrogen. In some women, she just uses testosterone on its own, and certainly sometimes she'll use estrogen as well. But she's published quite a bit on these pellets, and she's using pretty high doses. Like her pellets are giving you serum testosterone levels that are 2, 3, 4, 5 times sort of the normal range for testosterone, but she has done a really good job of tracking symptoms and side effects and things like that, and I don't know, she makes a case for, the higher doses of testosterone, at least in those women, are really great for menopause symptoms.
Yeah, I mean, it makes sense. I again, I've seen some of her studies. I've not seen those specifically, so I'll have to go back and look. But I think it does make sense, and it's another reason to relook at should we be using testosterone more freely. I know that was not part of the recent FDA panel. There was not a lot of conversation around testosterone, a little bit, but not a lot. And there was a recent. This didn't get nearly as much publicity, but there was a recent FDA panel for men too, and men in testosterone use. And with the whole conversation there was to get it off of the controlled substance list, right? So could we just like let's just not worry about abuse of testosterone, like from athletes in the 1980s. Like I think we can move beyond that. That would be huge because for us, even like we're in the telehealth space exclusively, I think we have around 30 states that we can prescribe in, and it's a constant battle to keep those states up and running. And so
Yeah.
for the women in those other states, there just needs to be an Amy in every single one of them, because because we can't do it, right?
Yeah.
Yeah. So then let's talk about how you use testosterone. You mentioned potentially pellets. What else are you using testosterone? What other forms?
I mean, pellets are not my go-to for I have done pellets and I did them for years. I think some women love them, but my go-to for testosterone are usually gonna be a transdermal, like a cream. Usually you can do a gel, like, but you could use a mids gel and kind of do it yourself. But if I have my way, I will, do a compounded cream that has her exact dose. Or I even like to do like subcutaneous injections in women and just kind of space them out, a couple of times a week just to keep it being from really peaking. But those are my two ways to do it. And I think that testosterone, one of the biggest kind of battles out there in the hormone space is around why you give testosterone to women. There's no FDA approved testosterone, but some organizations have at least are at least saying, well, if you have hypoactive sexual desire disorder, you have low libido, no thoughts of sex, like you have the situation, testosterone can be helpful, so we can do it for that. And so that's one camp. And then the other camp is, you know what? Testosterone actually does, we have receptors all over our bodies, just like estrogen. So, and it can be helpful for a lot of other things too. What if we also gave it for some of those other things? And there's just not as much evidence for that right now. And so there's kind of a battle going on for when do we give testosterone? I, I believe it could be helpful for a lot of different things, not just low sexual desire, but
Yeah, and I mean, I think this is one of the challenges too of creating protocols and trying to fit into, are we covering our bases? Are we doing this ethically, um, especially at scale? Because right now, I mean, the guidelines are not ambiguous. I mean, they are non-ambiguous. HSTD is the only reason to use it. We do not use testosterone for any other. Like there's insufficient evidence to use it for any other reason, which is a bummer because I see the benefit, and I have patients, people that have come to me who are on women who've come to me who are on testosterone, no estrogen, no progesterone for this whatever reason, and they're on a protocol to improve their bone, and we do see improvement in bone. The research around testosterone and bone is not great. There's a couple of studies. It's interesting. Susan Davis, who is one of the the big like do not use it for anything else spokespeople, which is fine. I mean, she does a ton of research in testosterone. That's her opinion. She has authored some studies on bone health who actually showed benefit, but they're small studies, right? And so it's like we need more data to say definitively how much the benefit is, but it's always a question of risk benefit. Osteoporosis and fracture, I mean, there's so much risk around a hip fracture. There's so much morbidity with spinal fractures that even if it were to increase BMD or increase muscle mass and not reduce fracture risk, still a reason to use it,
yeah.
right?
I think part of the problem is that in the low doses that were sometimes used in the studies to look at HSDD versus, other potential benefits, they're using 150 microgram patch or 300 microgram patch. And with that dose, it's probable that you're not going to have bulging muscles and a turned on brain. Like that's a small dose. I think it's a dose response thing, just like estrogen and any other hormone. And so the problem I think is that so I think we need a little bit higher doses, probably in some women at least, to see some of those other benefits. But then, of course, if you get too high a dose, there is the side effect profile with testosterone that is, it's manageable, but certainly some women don't love some of the side effects. So you kind of have to balance that a little bit.
Totally. And I want to get into side effects actually. Before we get there, I want to point out. So I live in both men and women's space. Do you treat a lot of men too?
Yeah, I treat men as well as women.
Yeah.
I talk about women, but I've treated men for years.
Yeah, and so, same where my platform has been very much about women's health and women's hormone health. But I do I run the men's health side of LifeMD now as well, and so we we're building these protocols. And in the men's health side is really interesting where the diagnosis is really androgen deficiency, right? Like there is even a scale called the aging male symptom scale. I think it's AMS, but it lists out like 40 different symptoms that are associated with aging, and about 39 of them are associated with low testosterone and low androgen,
I
right?
believe that. Yeah.
And we know that if we give men testosterone, those things get better, and yet we like that scale, that study doesn't exist in women, which is super frustrating. But I agree. The same thing actually is true with studies on testosterone in men. If you look, especially again, bone health,
Yeah.
increase in bone mineral density, but not reduction in fracture risk. But the doses they were using were too low. They were making them, normal. The
Right.
normal range is so low, it's so broad that they didn't have enough testosterone to make a difference. And the fact that they even saw a signal was like, wow,
I mean,
that's not
most
very much.
studies on men, they're just looking at, replacing men who are truly hypogonadal, who are, total testosterone is less than 250, 300, whatever the lab reports, and they're
Right.
getting them up into that reference
Above
range. But
above 300.
above 300, yeah, so I mean, and even the best studies, maybe they're 400, 500, but no one, as far as I've seen, has done a big study looking at what if we actually increase testosterone to more like what you were when you
Right.
were 25 or 30,
Right.
which, that I think is where we see a big
Well, and
change
where
in
yeah,
the
so let's just
field.
because it's so much easier for men because the ranges are more clear. But like, so for men, like, what are your targets when you look at labs?
I'm usually looking. I mean, certainly symptoms are still important because that's obviously part of it. But I want it to the total testosterone, if I'm using that, to be kind of mid to upper range. If the range is from 300 to maybe 1100, depending on your age, then I'm aiming for maybe 700 to 1100. Or I look at free testosterone, which unfortunately varies by lab, and there's different ways of measuring it. But I'm looking at middle to upper end of that free testosterone range also. So I want you towards the upper part, not towards the lower part, and then we're pairing that also with symptoms.
Yeah, when I was creating the protocols, that was so frustrating. And also when you look men versus women, they start using different units, and that's also very confusing. Um,
Yes.
but yeah, I was saying, we split it into tertiles. Like lower tertile, you meet criteria. Upper tertile is our goal, and the middle is, as long as you're feeling better, that's okay. But really, upper is our goal. But that means that we need to be doing studies. You're right, with total testosterone, 800 to 1100,
Yeah.
and that's not those studies are not out there.
And we need to figure out what's the range that we're even what's the range we're going for with women? Like maybe we should start by actually measuring labs. And if we don't measure labs, we don't even know we don't have any like old data to look at. Like it's it's kind of crazy.
Right. No, it really is. Yeah, and that's a really interesting thing with women too, is because we do see because the doses doesn't take a lot to get them to a range that's quote unquote too high, right? You say like, oh
Yeah.
my God, your total testosterone is 100, but at the same time, start measuring free testosterone, and we see this, and I bet you do too, quote unquote high total testosterone, but free testosterone that is still very low single digits.
Oh, 100%. Yeah. I
Yeah,
mean, even myself, I have a just genetically high SHBG. And so it's all,
same.
because, which is usually not a bad thing. It usually indicates, pretty good like metabolic health, but that does result in a lower free T3. I'm sorry. Yeah. No, a
Yeah,
testosterone,
that
free
too.
testosterone.
Yeah,
Sorry, I'm talking about thyroid now. So, for someone like me, I was taking testosterone and my testosterone was like, I don't know, 150 or something, but like my free testosterone was like 1.2. Like it was like it
right.
barely moved.
Right. Yeah, I have to keep mine around 1,000 in order to keep my free testosterone in range.
Yeah.
And same. And I was one of those guys too that had total testosterone in the 500s, but a free testosterone of less than 5.
Yeah.
Right? So like I wouldn't be a candidate for treatment. Unfortunately, I had a good doctor who was willing to treat me, and I feel totally different on optimized testosterone.
Yeah.
Yeah.
It can be a game changer, I think, for men and women.
Totally. So then let's talk about the side effects, because this is, I'm sure you hear a lot of this, the side effects are they're they are feared because they are things that a lot of women care about, right? So like hair falling out, hair growth. It's funny that it does both. But hair growth in places you don't want it, hair falling out in places where you do want it, oily skin, acne, and those are the biggest ones that I hear. And also, I will say that for me, my patient population tends to be older, right? So I'm treating mostly 60 plus. And I find that the older they are, the less they tolerate from a testosterone perspective.
Okay.
And so I'd love to hear your thoughts on what you're seeing in patients and what you do about it.
In studies that have been done, and this is true, I think, in my patient populations, are we know that testosterone, even at low doses, can cause increased facial and body hair growth and acne. So certainly higher doses, you get more of that. But even at relatively low doses, even in the HSDD studies, those are the two side effects that they were most commonly seeing. Now, what's interesting is the one of the side effects I hear about the most is hair falling out, hair falling out.
Yeah.
And we don't, I mean, certainly I believe women who say their scalp hair is falling out. Like I believe you. However, the data so far that doesn't actually show that testosterone tends to cause your hair to fall out. We do know that about 50% of women in midlife will have hair loss, will have hair shedding. And probably that's due more to estrogen going down and progesterone, which is good for hair, and other things, stress going up, cortisol, whatever, all the things. That's probably more about that than anything else. But it happens at the same time that we're giving testosterone. So we give testosterone, someone thinks that their hair is going to fall out, they're at the right age, maybe it is falling out for some other reason. They blame the testosterone and it gets a bad rap. Certainly, I think in some cases, testosterone can increase hair shedding. People who have androgenic alopecia, they're prone to it. Makes sense that it would happen. But in the studies, including Rebecca Glazer studies with the high dose testosterone, including like all the ones that are kind of the lower dose for HSDD, they did not actually see increased hair loss in those women.
Yeah, and that's my interpretation of the research too, is that it's not dose related in the studies that have been done. You know, like, if you go back and look at the HSTD studies, like there was not a significant difference in the higher doses. Granted, they weren't actually that high, but still, you would expect to see at least some signal there. And so, yeah, Sam, I tell my patients, I believe you. I believe that you're losing hair, but hair loss is challenging because there are so many reasons why you could be losing hair. And then to blame, especially at the end, they say like, I started testosterone last week and I'm losing hair. Like
Yeah,
that's too early, and that's
it's too
probably
early.
because you looked it up, and now
Exactly.
you're noticing that you're losing hair. But it is hard, and I appreciate, as someone who doesn't have a lot of hair, I appreciate that hair can go a long way, and women don't want to lose hair, and I totally respect that. But then the question is are we getting, what is the benefit from the testosterone, and what's the risk, and what do you do with it?
It is hard because if you decide that the hair loss might be from testosterone, but you're not sure, you stop testosterone, well, it takes 3 to 6 months for that hair to grow back. It's not like an easy thing where you can just do a trial off of it and then do it back on. Like you're waiting, half a year to see if something happens. There are some things that we can think about in terms of reducing those effects. Certainly, there are some topical hair peptides, medications, red light therapy, things like that that can be used. Sometimes spironolactone will be helpful. That can be given orally or even topically for hair or skin concerns. So it's not like we don't have any way to still use testosterone, but at some point you kind of have to figure out like is it worth it or not if you think that that's causing hair loss.
And it's hard without good research to say, like, how much benefit are we expecting? It's so much easier with estradiol to say, look, I can tell you likely what the outcome is going to be here if we can stick with it, if we can find a way through this. But with testosterone, it's sort of like, well, we tried. I don't know what this is doing anyway, and then I'm out. But where we should see the biggest impact is in the sexual function side. So I want to ask you about that because we've been really digging into some of our numbers on this, because if you look at the HSTD research, it really isn't actually very impressive. And I hear some opponents to testosterone saying like, look, it really doesn't help that much anyway. But again, they don't have enough testosterone. They're not actually
Right.
optimized. So then if you're a doctor who optimizes hormones and optimizing testosterone for women, what are you seeing from a sexual function, a desire, libido, like all those terms? Like, what are you seeing?
Well, I think in both men and women, increased sexual desire and sexual thoughts is one of the first things that we see when we give testosterone at a meaningful dose. Like it's all of a sudden, I'll have patients come in and say, I hadn't thought about sex in a long time. And now, like, whenever I go out, like, I'm looking at the random people in the grocery store and I'm picturing them naked. And this is like a 55-year-old woman who hasn't like, this has not been in her brain for a decade. So I think that the desire, that sexual kind of thoughts is the first thing. And then certainly as you have that, then we also can start to see improvements in things like just sensation and pleasure and some of that. Estrogen is also obviously very important because we want to get estrogen in that area to make sure the tissue's healthy. But both of those things. When you look at like the sexual response curve for women, at least, estrogen, progesterone, and testosterone all have a role in that kind of desire, arousal, orgasm piece. Testosterone hits all of those things, and then estrogen is important for some of them, and progesterone as well. But so we gotta do all of it. We can't just do part of it.
Right. Yeah. Again, hormone optimization for those that can tolerate it. The one that we left out here was thyroid.
Yeah,
And you actually you wanted to jump into free T3.
I did. I jumped in too soon.
Yeah. Well, let's talk about thyroid because this is one of the things when I was brought in to create these protocols, and they're like, can we not treat thyroid? Because it's
Yeah,
complex. And I was like,
it
man,
is.
I wish. I wish. The same thing. Like some days I wish I didn't test my patients. But yeah, I think we have to talk about thyroid if we're talking about sex hormones because they are so related. The symptoms overlap so much.
So
You know,
much.
and
Yeah.
if a woman's losing hair, like, oh, I forgot to check your thyroid. It could be a big part of it. So, boy, can you just give us the rundown on like what's your approach with thyroid?
I mean, thyroid is so complex, and I mean, I change my mind about things or learn new things about it all the time. So, I mean, we check thyroid, we check, we check TSH, free T3, free T4, thyroid antibodies, and reverse T3 in at least all of our baseline visits on people. And so then we're trying to correlate those numbers with specific thyroid symptoms if we can. The problem, as you mentioned, is a lot of thyroid symptoms are also menopause symptoms, are also perimenopause symptoms, are also I'm stressed out symptoms. And of course, there's a big interplay between just stress and the stress response and being overloaded with stress and a lot of those like thyroid symptoms. So in people who have pretty classic thyroid symptoms, low thyroid symptoms, I don't treat high thyroid, I send them out to endocrinology. If they have low thyroid symptoms and you know their like their TSH is more than maybe 2 or so, and or their free T4 is or free T3, either one, but especially T4 is on the lower end. We might try a little bit of thyroid and see, does this help your symptoms? And then just kind of go from there. I like to keep thyroid hormones within the normal reference range for the lab. I'm not someone who wants to push those outside the reference range. I have seen, including my own husband, people who develop arrhythmias from having just a little bit too much thyroid on board. My husband who's super fit and super healthy, who was taking a little extra thyroid, not from me, from someone else. And he got into a cold plunge one day and went into AFib. And he was just like, we had to go to the ER. It was a whole thing. So he's fine. But, thyroid can do that. Like it is a little bit of a scary drug if you use too much of it.
And when you say give them a little thyroid, what are you treating with?
We're usually using a desiccated thyroid or a combination, T4, T3, either in most often like an Armour thyroid or NP thyroid, but sometimes we'll use another product.
Yeah. And so what do you think is happening right now with the potential ban on those products?
I feel like I don't know. Thyroid kind of got I was just listening to a podcast about from one of the thyroid researchers who wrote a book. Thyroid kind of got grandfathered in with the FDA, like all the desiccated products. So they were never really like FDA approved, didn't go through clinical trials. The same thing is true, by the way, for levothyroxine. It also kind of got to skip a lot of clinical trials. We don't actually have good clinical trial data on this stuff because they've been around since like the early 1900s. So I don't think, I can't imagine they're gonna really take desiccated thyroid off the table. I can't imagine. Like, doctors would be very angry.
I'm going to send this podcast to you in 6 months.
Yeah, send it to me in 6 months and I'll be
We're going to see. Well, I hope that's true, because we have, that's kind of how I was trained as well, and I do find that a lot of our patients they just do so well on desiccated thyroid, and we have gone through the effort of creating alternative protocols in case it does go away in quickly. And so now we're using all different things, right? So we do find, I do have some patients that do okay on T4 only therapy, and
yeah,
that's fine.
sure.
Um, but I am also finding that now some of our providers are really enjoying actually creating their own T4 T3 combos. And that's, we've just never needed to do that. It's more work to do that, but it is nice to now you can actually ask and say, well, let's really dig into your symptoms. And if we think this is still thyroid, like, can we continue to manipulate this? So I hope it doesn't go away, because it is the easier way to do it for sure. But at least we do have those T4, T3
Yeah,
alternatives and they're out there.
exactly.
Let's then pivot to some over the counter stuff. So everything we talked about so far requires a doctor.
Yeah.
And not everybody has great access to doctors, and certainly not everybody has access to you, although we're going to tell them how they can find you shortly. Um, but I know you're involved in the space around supplements, and I think you have a company around that. So talk to me about what you have done, because I'm sure you've seen just about every supplement under the sun. So when you got into the space, like what did you decide was the most important?
Well, about 5 years ago, I was taking I would go to listen to all the podcasts, read all the papers, and then I would just go out and try to find all the different supplements that I wanted to take for myself and for my husband and had all the pill bottles and all the things. And I was kinda sick of it, so I decided, like, what if I'm just gonna create something that's like a packet that has the things that I want to be in there. And so I created a product, it's called Hotbox, which is still around, it's our only product. We only have one product, but it's a women's longevity focused product that is basically looking at attacking the key drivers of aging in women and then helping to improve symptoms like low energy and skin and hair problems and mood problems and things like that. So we have a single product. It's like these little packs, slot box packs twice a day. And it's great. We get so much feedback from people. We're running our first small clinical pilot study with women here. Like we're working with Reputable and doing a wearables plus lab data epigenetic study on the product and see kind of what we find. But it's one of those things I never expected to get into the supplement space. Like I was never someone who was like, I want to have a supplement company. It was more like I wanted to create this one thing for myself. And then like, I'm still at it just because I think it's such a good product.
Yeah. So can you tell us what's in it?
Yeah, I mean, there's a bunch of stuff in there. Certainly, you've got, like, your vitamin D3 and some of your B vitamins, but aside from that, we're not trying to be like a multivitamin. I think you can get a lot of that from food, but we do have we have some of the kind of longevity darlings like spermidine and nicotinamide riboside and calcium alpha ketoglutarate. We also have some things that are great for blood sugar and inflammation like dihydroberberine and curcumin. We also have a lot of good antioxidants like astaxanthin, apigenin, trimethylglycine. There's 19 different things, but we kind of tried to like be very strategic about, how to like for instance, we have NR, which as you know is a precursor to NAD, which is good for your cells to make energy. But NR, you don't want to use it by itself. You also want to pair it with something like apigenin to help decrease the breakdown of NAD, and then you also want to give back some methyl groups. So essentially, like how do each of these work and what else do they need to work well? And then put all of that into a, 5 pill pack.
I love that. 5 pills is not a lot of pills for all those things.
It's not. We actually, it is, we created everything ourselves. So it is just 5 pills, 5 pills twice a day, essentially.
Yeah, that's awesome. I love that. That's a great approach. Can I ask about, and if you can't say it, it's okay. But what wearables are you using in your research? Can you say that out loud?
Yeah, so we're working with a group called Reputable, which is a separate company that does these kind of real world clinical studies, and they have a bunch of different options, but like Aura Ring, I think they are working with, or we're going to work with Ultrahuman, Whoop, like some of the different bands. So the people will have some kind of wearable that they're using, and then we're also using True Diagnostics. Epigenetic testing to look at various markers, and that will be kind of their bigger test. So we're looking at not just how fast are you quote unquote aging, from that biological age test, but also some of the other kind of indirect markers like estimated blood sugar and estimated, things like that. So I think and plus subjective data. How are you feeling? How's your energy? How's your sleep? All of that will go into it too.
Yeah, that's amazing. And is that study going on now?
We are actually recruiting for it right now. Well, Reputable is recruiting for it. They're kind of in charge of that. But yeah, it's women, like midlife women, and we'll be kicking it off like officially in the next couple of weeks.
Amazing. How long will it run?
It is a 3-month study. So 3 months we'll do labs and wearable data before, and then 3 months of treatment. And it's not a blinded study where this is just a kind of a pilot. And then we'll analyze data, and then we'll, see kind of what we see, and then we can hopefully fund a bigger study after that.
Yeah. Will you try to publish this pilot?
Yeah, yeah, if everything, we gotta see what we find, but if we find good things, then we'll definitely think about it. We have an IRB, of course, and our research coordinator is, we're looking at a path to publishing and keeping our options open.
Yeah, cool. So probably 2027, I would imagine, earliest. But
Yeah,
that's exciting. I love
that
that.
and my book can be published together maybe.
Yeah, yeah. Well, let's talk about your book. So let's talk about like what you're thinking is going to go into this thing.
So I'm writing a book. I have a publisher. They're it's legit, but it's probably going to be early 2027 before it comes out. The name is not official yet, but it's basically a women's longevity book through the lens of reproductive aging and how ovarian aging and kind of the eggs and the egg concept shapes women. And it's about the women's longevity benefits, like the things that we have that are actually our longevity superpowers, because women live longer than men, about 5 years longer than men across all cultures and socioeconomic levels all over the world, and we have for a long time. So like what is it that's within us that helps us to live longer? And then what happens in midlife, that kind of collision of loss of hormones and changes in lifestyle and environment, what happens to kind of derail us, and how do we stop those things from happening?
Amazing. Well, I look forward to reading that. Tell us where we can find more of your stuff. You're doing so many things, longevity, hormones. I see you everywhere, but I think it's because my feed likes you. So where can people find more of you, both clinically and virtually?
So I am very active on Instagram, Dr. Amy B. Killen. I'm also on, other things, Facebook and I don't know, YouTube and all that, but mostly Instagram. And then my website is dramykillen.com. And that's probably the easiest place that shows you all my other things. I've got, Hotbox, I've got Humanot Health, I've got my own clinic in Utah. But if you go to dramykillen.com, you can get a roadmap to find me on the other places.
That's amazing. Okay, one final question, and I ask everybody this. If you were given the keys to the kingdom of the new healthcare system, meaning that we are able to create a new system that serves people the way that you want to serve people, both women and men. What's the one thing that you would change to get us there?
And this is a hard one, but I would really try to have a kind of science-backed single-ish source of truth. Like, I feel like the biggest problem we have in medicine is that people don't really trust doctors anymore, that they think, I think that we're all lying and money grubbers and that we don't know how to read literature. And I don't think that that is generally true, although maybe on the periphery. But I think that there's a lack of understanding of like what do we know, what do we not know? Whether it comes to hormones, whether it comes to menopause, testosterone, like anyone can get out and say anything. I would love to see some sort of method that we can actually kind of cull the data and say, like, this is what the data actually shows around this. And here's what we need to do to figure out more data. And then kind of go from there. Because once we know what's true and not true, then we will do a lot better decision making.
Yeah, interesting. Do you think AI can help us do that?
I think AI can help. The problem is AI also regurgitates a lot of what's out there. And sometimes it just gets stuck in loops telling you things that are not actually true. And I see that a lot because I use AI quite a bit every single day, but I'm always having to check sources because it makes stuff up all the time.
Well, especially with hormones,
Yeah.
right? Like it's amazing. I mean, I in our community that I help run, I teach people how to use AI, especially the older generations, right? I'm teaching them how to use AI from a healthcare perspective. Like, you have so many questions. You cannot go to all the specialists just constantly and be asking them these questions and then get conflicting answers. You need to learn how to ask AI because it can be a powerful tool. But I always warn them there are areas where it's going to hallucinate, and hormones definitely one of
It hallucinates or it latches on to it'll latch onto a 20-year, study or paper or something where someone said something and then it'll be like, yeah, estrogen is bad because it does, it causes blood clots. But they're not taking into it the nuance that transdermal doesn't. Like there's things like that. Like it just will make broad statements that aren't actually true a lot of the time.
them. Yeah. Well, gosh, yeah, a single source of truth would be amazing. I haven't
I mean,
heard
it's
that one
not
yet.
going to happen probably, but if you're asking if I can dream,
Hey, you got the keys to the kingdom. You can build it.
right.
Awesome. Well, Amy, thank you so much for your time. I really appreciate it. Always good to hear how you view hormone optimization. I think this is, if we're going to build a new system of healthcare that is focused on prevention, focused on longevity, focused on health span, I think this has to be the way that we do it.
Yeah, agree. Thank you for having me.
Yeah. Have a great day. That's it for today. Thanks so much for your time. And I hope you enjoyed this interview with Dr. Killen. And remember that this is Health 3.0, where precision meets purpose and care remembers its humanity. I'll see you in the next episode.